आप लोग अपना खाते पीते रहो पीछे ना.
Mansi,
Yes, sir.
I think Dr. Moore is having some problem with getting in.
Okay,
I received the mail.
a
Yeah.
minute. So, do you want me to talk to him? If you can share his contact, should I?
No, I don't have his contact, but I will again forward the link to him.
Okay, I will also send.
Hi, Bo. How are you?
Yes, Shirai. Wonderful.
Yeah, I'm
It's
fine.
fine with me. Good to you too.
Yeah, nice to see you.
Yes, wonderful.
Good morning, Bo.
So, hello. Wonderful.
What
Great to
time
see
is
you
it in
person.
Sweden?
It's good. It's good.
What time is it there?
It's 2 o'clock in the afternoon, so it's quite good.
Ah,
Yeah, it's very early for you.
yeah, not too early.
Not too early. Yes.
Sir, I've resent the link to Professor Moore.
Good evening, Professor Carroll.
Good evening.
Thank you for joining.
No, my pleasure. Thank you.
Hi, Bill. What time is it in Australia?
It's 9 p.m., Lou.
Ah, okay.
Where are you?
Boston.
Right. Okay, so 9 a.m. I
Cold. Cold and a little bit snowy.
guess. Hi, Bo.
Hello. Hi, everybody. Good to see you.
Yep.
It's 8
Ah,
a.m. in
there's
New York.
JC.
How are you, Lou? Pleased to have the opportunity to participate. I hope I can be heard.
Yeah,
Bo,
hello.
Bo
Yeah.
Norgren, it looks like you're trying to go to sleep. Is it that late in Europe? I thought it was only 1
no,
o'clock.
I'm just relaxing. It's Saturday afternoon and it's a very good day at home
Yeah,
to work. Yes. I'm having very comfortable here.
Yeah, I think, Gagan, we can start.
with pleasure. I was offered the opportunity to introduce our speaker, and Lou Kaplan and I have been linked together for such a long period of time that everybody actually knows him through his wonderful book on Miller Fisher better than some others of us here in America. But he's a distinguished professor, as everybody knows, trained with Miller Fisher in the years after I did, and we have been associated professionally for years.
Yeah, Professor Moore.
Yes.
Yeah, so should we start now? I will hand over to you when you have to speak, introduce Professor Kaplan.
Okay.
Okay, so Gagan?
Means to say, there is a little bit of introduction, and if you kindly permit us to do the introduction as it's an important formality, you know, and it needs to be done. So
Yes,
thank you.
I'm happy to do my part.
Thank you. Yes. Thank you, Professor Moore. So this is second in this series, and I feel I'm really inspired, and I cannot just thank Dr. Meshram enough for having conceived and done all the hard work for this excellent and wonderfully planned series. So I think the stage is entirely with Dr. Meshram for the time being, so that he introduces the topic and all the dignitaries on the dais or the stage or the panel today, and then goes ahead and we go ahead with the proceedings. So Dr. Meshram, please, can you please take stage and do the necessary introductions. Thank you. Thank you so much.
Yeah, thank you, Dr. Gagandeep Singh. Dear friends, good morning, good afternoon, good evening, buenos dias, bonjour. On behalf of Tropical and Geographical Neurology Specialty Group of World Federation of Neurology and Indian Academy of Neurology, I welcome you all for this new series, Inspiring People in Neurosciences, to be held on first Saturday of every month. In this series, we will learn about legends who have done great work in the field of neurosciences. The idea is to ignite young minds to do outstanding work in the field of their choice. Inspirational person today is Professor Charles Miller Fisher. I don't think there would be any neurologist in the world who does not know Professor Miller Fisher. Almost all neurologists are inspired by him directly or indirectly. He mentored many neurologists and stroke specialists, including Professor Louis Kaplan. So he's the best person to talk about Miller Fisher. Warm welcome to you, Professor Kaplan. To chair this important session, we have Professor J.P. Moore, who had about 15 long years association with Professor Miller Fisher, and will also share his memory after the talk. Presently, Professor Moore is Daniel Sierra Professor of Clinical Neurology, Director Doris and Stanley Tannenbaum Stroke Center, Director Horace Goldsmith Neurovascular Laboratory, Neurological Institute, Columbia University Medical Center, New York Presbyterian Hospital. He graduated from Virginia Episcopal School, and after further training in medicine and neurology, he joined as fellow in neuropathology, Mass General Hospital, Boston in 1966. And then he became a fellow in neurology and stroke service under Professor Miller Fisher at Mass General Hospital, and then served as assistant professor in neurology at Harvard Medical School and Mass General Hospital. He had a very illustrious career. He received many awards, and the notable being the Raymond D. Adam Award, Miller Fisher Stroke Visionary Award, American Heart Association 100th Anniversary Lifetime Achievement Award, and Albert Nelson Marquis Lifetime Achievement Awards. He had more than 370 publications, 16 editorials. He authored 8 books, 87 reviews and chapters, and countless abstracts. He served as editor of Stroke History section. He's on the editorial board of many journals and delivered invited lectures and served as visiting professor all over the world. I also take this opportunity to welcome invited panelist, Professor Bo Narving, who is Professor of Neurology, Lund University, Sweden. He was President of World Stroke Organization from 2008 to 2012, and presently he chairs the WHO Global Policy Committee. Welcome, Professor Bo Narving. In the room, we have other panelists, and I would like to welcome WFN President, Professor William Carroll, WFN Past President, Professor Raj Shakir, WFN First Vice President, Professor Yuji Kazi, WFN Secretary General, Professor Wilfeng Griswold.
Aye.
IAN President, Professor J.M.K. Murthy. WFN Trustee, Professor Steve Lewis. Director of Neurosciences at Bombay Hospital, Professor B.S. Singhal. World Stroke Organization Vice President, Professor Jairaj Pandian. Professor and Head of Neurology at PGI Chandigarh, Professor Vivek Lal. Past Secretary of Indian Academy of Neurology, Professor Gagandeep Singh, and others. And I welcome you all. I am sure you will enjoy this session, as the stalwarts will be talking about stalwart, and there will be a heart-to-heart talk, brain-to-brain talk, and mind-to-mind talk. Yesterday, Professor Moore celebrated his 84th birthday, and on behalf of you all, I wish him a long and healthy life. Over to you, Professor Moore. Thank you.
Happy birthday.
Well, this is JP Moore speaking. I think I'm allowed to speak again, but maybe I wait and see what happens.
Yes, please carry on, Professor Moore. And happy
Okay.
birthday, belated happy birthday.
Yes, I'm delighted to have the opportunity to introduce my long-term friend and co-trainee, Lou Kaplan. Everybody knows that he was a fellow the year after me at the Mass General Hospital, and the two of us have been linked together for all these years, including the experience we had with Miller Fisher, who I'll be glad to comment on at the end of this talk. He has been a distinguished professor of neurology at Harvard and is a neurologist at the Beth Israel Deaconess Medical Center now, but previously was at the Beth Israel. Everyone knows that he was chief at Tufts, that he was in Chicago, came back, and I think he is firmly embedded in the Harvard community and will be there till the end of time. So with great pleasure, I introduce him to you and look forward to his comments.
So should we request Dr. Kaplan to talk? Yeah.
Good morning or good evening, friends and colleagues. So Charles Miller Fisher, he didn't like the term Charles and never called himself that. He wanted people to call him Miller. Having trouble. Miller grew up.
So you can click on.
Yeah, I got it. Miller grew up in a very small town called Kitchener, which was attached later to Waterloo as the Twin Cities. You can see its relationship to Toronto. It was a fairly rural town. It was populated mostly by German settlers and actually Mennonite farmers, and was relatively rural. Miller was born on December 5th, 1913. He was the third child. He had an older sister and older brother, and then 5 other siblings followed. So Miller actually had 8 siblings. Unfortunately, his mother died in childbirth with the 10th. So he was raised primarily by his father and 2 maids who were Mennonite sisters. Here's the house that he grew up in with his siblings. It was a fairly strict upbringing. There was no alcohol in the house. One had to get to dinner at a certain point. One had to eat all their peas and vegetables. And you had to do exactly the things that the father said. And this is how Miller wrote a memoir, and he talked about his own hometown. And this is what he said. The community was deeply religious, and the several churches were the community life for children and adults. No radio, no television. Summertime boys played softball, tennis, swimming, fishing. They also tended to their pets. They built model airplanes or kites. In the winter, hockey, ice skating, badminton recreation, alley bowling was introduced later. There was some puppy love, but no dating with girls until you were about 17 or 18. The action in the town was mostly related to church societies. They had wiener roasts, corn roasts, church picnics. Recreation was little engaged in with women except square dancing. I didn't start dating till you were 18. Wouldn't it be wonderful now when we think of our children or grandchildren or great grandchildren if things are so simple and lovely? So then Miller went up over to the big city, to the University of Toronto Medical School, where he stayed for 8 years. This is a picture of him at that time. And this was the Toronto Medical School, it was actually part of the university. So you had a choice if you went there. You could take a straight medicine curriculum, which was 3 years of science, 3 years of medicine, or a much harder course was a curriculum in biology and medicine. So it turned out in the straight medical curriculum were most of the people. It was much easier. There were 120 men and 20 women in the straight medicine. In the biology and medicine course, there were only 25 men, no women. And this was the nature of the course. On the right, you can see the variety of subjects, mathematics, there was some physics, some literature, but it was primarily science. And then on the left were the medical school curriculum. Miller thought that the plain curriculum in basic things was much more rigorous, and medicine was more happenstance. The doctors really were on their own. There was no uniform curriculum. It was not a very intense course in clinical medicine, but the basic sciences were very well done. Then he was very fortunate. He applied and he got an internship at Henry Ford Hospital in Detroit in 1938, 39. And he said the medicine there was absolutely wonderful. There, one of his long-term colleagues and friends, Bill Fields, who was a major factor in stroke, was also there. And it was a wonderful time spent mostly only doing general medicine. Now, at that point, you were allowed to spend only a year because he was Canadian. So he went back to Canada and he looked around where he could get some postgraduate training. And the best place at all was Montreal. So he spent time at the Royal Victoria Hospital in 1939, mostly doing internal medicine, infectious disease, which was very prominent at that time. And he became very interested in metabolism and especially in diabetes. So insulin, of course, had been discovered in Canada, and you meticulously kept track of blood sugars and metabolic things. And that at that time was where he was mostly interested. Now, this was, of course, near the beginning of the war, and it was clear what was happening in Germany. So Canada entered the war with the United Kingdom in September of 1939, and Miller enlisted in the Navy. It's a long story, but what happened, he was really bullied by one of the senior surgeons. A senior surgeon was supposed to join the Navy, and he decided there wasn't much surgery in the Navy. You were on board a ship. He wanted to be in the Army. So he asked Miller and cajoled him to take his place. So Miller enlisted in the Navy in April 1940. At that time, he was assigned to examine recruits on His Majesty's Canadian ship, the Donnacona. And there he was very interested in heart sounds and listening to heart, but there wasn't much medicine. He was later, following commands, was posted to His Majesty's ship Voltaire. Unfortunately, the ship was sunk by a German submarine on April the 4th. Now this is Miller, this is Miller far to the left, and these were the surgeon lieutenants who all joined together. These were all doctors in the Royal Canadian Navy. Here's the ship, the Voltaire. And on April the 4th, 1941, while on duty, his ship was sunk. He spent hours floating in the ocean. And at this point, he'd been married for a year, and his wife was expected to deliver that very day. was very nervous, and a Navy boat came by. He was aboard the Navy boat, and then he was taken to the Stalag prisoner of war camp located in Sandbostel, Germany. And there he spent the next 3.5 years as a medical officer in the prisoner of war camp. And you can see here on the right, the letter that was written to his wife. There was a series of 3 letters. The first was, "It is with deep regret that I confirm the telegram that Lieutenant Surgeon Charles Miller Fisher is missing on active service." And you can imagine the nervousness. She finally got another one that said, "We found him. He's in a prisoner of war camp." And these are a couple pictures of the camp, the Marlag camp and the Western Mink camp. And here on the left is Fisher with other 2 doctors. And then here you can see on the right what this camp was like. Now, there wasn't much medicine in the camp. They had very little in the way of equipment, but it was a little bit like if you read Nelson Mandela's comments about South Africa, they tried to do the best they could. So they had courses. Miller learned quite a bit of physics. He learned German. He read Shakespeare and other literature. They played poker. They organized activities, actually theater and music and instruments. And actually, the American Red Cross delivered a lot of packages. And Miller's account of the time in the camp in the memoirs is really remarkable. He also mentioned that a lot of the guards were not too happy with Hitler and were actually anti-Hitler. And they were able to sneak in radios that kept them posted with what was happening all over. But in the 3.5 years, there was very little in the way of medicine. And he was lucky enough to come home in 1945. So he came to Canada, he was reintroduced to his family, and he now had to learn medicine because it had been, 3.5, 4 years. So he took a refresher course at the Royal Vic Hospital that I showed you before. And this is a picture of the Montreal Neurological Institute, which is attached with a bridge. You can see it down here with the Royal Vic. So he was actually a house officer at the Royal Vic and spent some time at the Montreal Neurological Institute, the MNI. And he happened to be under Walter Penfield. Now, Walter Penfield was a very imposing man. And actually, Miller had one case that he was assigned to. It was a man who heard roaring in his ears before he passed out and had a seizure. So Miller went to the library and he looked it up, and he found out that the roaring in the ears had something to do with Heschel's gyrus, and the sound came primarily from the right. So Miller, when Penfield asked him what he thought was wrong with the patient, he said he probably has a tumor in the temporal lobe near Heschel's gyrus. And Penfield was duly impressed. He pushed Miller, and Miller spent some time at the MNI, and then he decided to become a registrar, a house officer at the Montreal Neurological. And his other activities were in some of the Veterans Hospital in Montreal. You remember they were coming home from the war, and a lot of these veterans had strokes. So Miller, by this time, was invested in neurology, but everybody told him he needed some more formal training in neurology. He wouldn't get that at the MNI, and they all told him he should go to the Boston City Hospital, where there was Derek Denny Brown and Raymond Adams. So Miller went off to Boston, and then after that training, and I'm going to say much more about the training, he went to Montreal, set up a neuropathological laboratory at Montreal General. That was the same place where Osler, years before, had set up a lab. And then he did clinical activities at St. Mary's and attended rounds at Montreal General and the Montreal Neurological Institute. And then he was invited by Raymond Adams to join him at MGH. So Raymond Adams had been with him in 1949 previously. And then he started the stroke service. So this is a picture of the Boston City Hospital right in the middle of Boston. A lot of buildings. One actually lived in the area. And here is Dr. Denny Brown. Denny had been actually brigadier general in the Army and had been recruited to Boston. He also was very tyrannical and was basically a physiologist. He had worked with Sherrington and was a clinical neurologist. And on the right, you can see Denny. This was a Saturday morning session examining a child, and everyone was dressed in a white coat. Everyone was terrified about presenting to Denny. And here's pictures of Raymond Adams. This is as a young Adams in a neuropathology lab. Now, Adams had been at the city, but Houston Merritt was there. And when Denny came, there were only 2 salaries. So people told Raymond, if you want to stay there and you want to earn a living, you have to do neuropathology. So Raymond learned neuropathology and actually was taught general pathology and neuropathology. And here on the right, you can see Adams when he was much more mature. Alan Roper is going to present, I think, the next one on Raymond Adams. So this was Miller's comments in his memoirs about the two. He said it was a two-man show. Dr. Derek Denny Brown, handsome, dignified, polished, articulate, autocratic, authoritative, betimes choleric. After attending one of his lectures, medical students all aspired to be neurologists. Dr. Adams, equally articulate, was a model of tolerance. Every case, every inquiry was the occasion for penetrating yet ranging accounts into every facet of a problem. In some areas, Dr. Denny Brown was superior, and in many other areas it was Adams, but together it was a performance that bordered on the amazing. One left feeling incredulous. Ultimately, my exposure to the anatomy and neuropathology of neurological disease under Dr. Adams gave me the feeling that before that time, I hadn't really lived neurologically. Having learned basic neurology without immersion in neuropathology, achieving a visual spatial thought is not only fundamental, it is the only method. So Miller decided then his career was going to be in neurology, and actually he encountered some stroke patients that would be in stroke, and he would be both a neuropathologist and a clinician. And if you asked him what he was, he would often say he was a neuropathologist. So when he came to set up shop, he went back to Montreal, to the Montreal General. He had decided to devote his career to the study of stroke. They gave him a lab at MGH, the Montreal General Hospital, and it was the same lab that William Osler had set up years before. You remember Osler actually was a pathologist before he did clinical work. He saw patients in the neurology outpatient clinics at the St. Mary's Veterans Hospital, and he was a neurology consult for inpatients there. He also saw patients at St. Anne's, which was also a veterans hospital, and he attended teaching rounds at Montreal General Hospital and the Montreal Neurological Institute. And this is the Montreal General. It's a very big public hospital, which also had private patients. And this is where Miller lived with his family at the time in Montreal. And Miller thought that he would spend the rest of his life in Montreal. He was basically Canadian. He was very loyal to Canada, and he was very patriotic. And this is Miller at that time. This is on the left, a formal picture. And this is Miller with his children, Elizabeth, who was the oldest, Peter, and Hugh. Elizabeth became a lawyer eventually, and Peter and Hugh became physicians. So at that time, Miller did a number of things that were really remarkable in a 4-year period in Montreal. First of all, he was one of the first people who really called attention to carotid artery disease and linked transient monocular visual loss with carotid disease. And he was one of the first people who talked about transient ischemic attacks. Actually, in talking to the veterans people, they all told him that before the stroke, they had these various episodes, and Miller looked up that issue. So he had done work on these 3 areas. He also, in the path lab, had seen some lacunes and was interested in the underlying vascular lesion, but he didn't have the technology in the pathology lab there to do it as much he wanted. He was very interested in brain embolism. He had gotten that interest at the city hospital doing postmortems. He also was working on the distribution atherosclerotic disease in the neck and intracranially. When he found out about the carotid disease, before that, everyone had thought that the lesions were intracranial, middle cerebral artery. So he became interested in where actually in a whole group of people are the vascular lesions. And he and the Dieners in the path laboratory collected a group of specimens to try to analyze the locations. He was very interested in atrial fibrillation and was really the first one who called attention to that as a source of embolism. And he made sections of the heart and found thrombi in the atrial interstices. And he there in Toronto described the Miller-Fisher variant of Guillain-Barré syndrome. This was all in 4 years. So this is his account in the memoirs of that first patient. A veteran told me that during the weeks before his stroke, he had several attacks of temporary blindness in one eye. And while Fisher was writing his consultation note, the veteran remarked, "Isn't it funny? I went blind in the wrong eye. I'm paralyzed on the left side, but I went blind in the right eye." Another week, another veteran told Fisher a similar story. He said that before he had his stroke, he was sitting in his favorite tavern when he went blind in an eye. His friends who were with him reassured him that it would go away in a minute. He said everybody has those things. They told him he was probably drinking the wrong booze. He should start drinking beer. The eye symptoms recurred several times before the stroke. Again, the blindness was on the wrong side. The temporary blindness involved the eye on one side, and the paralysis affected the limbs on the other side of the body. Now, what happened was that one of those patients died over a weekend. Fisher was away. When he came back, he spoke to the wife and convinced the wife to have a postmortem. And late at night, he and the person at the morgue where the body was cut down on the carotid artery, and he found it occluded. And it was really the first then of trying to collect specimens of carotid disease and trying to inquire in depth of the veterans about TIAs and transient monocular blindness. And these are some of his drawings. You can see on the left a cartoon where he noted where the carotid lesion were, and on the right, the pathological specimens of occlusion, and looked at the arterial wall. So he was very much into clinico-pathological correlations, and he wrote 2 articles, one in 51, which was the first article on occlusion of the carotid, and the 54 of further experiences, and then he reviewed in detail the literature on those subjects. Now, he also became very interested in brain embolism. So he wrote this when he was a neuropath fellow. I had the opportunity to examine the cerebral arteries before slicing in 3 brains that had large hemorrhagic infarcts. The basal vessels were empty of thrombus. So people were signing these out as middle cerebral artery occlusions, but pathologically, there was no thrombus. Afterward, he looked up the records of these cases, and all had atrial fibrillation, and an autopsy had shown infarcts in the spleen and kidneys. And he and Adams later wrote up this issue of hemorrhagic infarction, that at postmortem, here would be the infarct, this would be the hemorrhagic portion, this would be the bland portion, and at postmortem, sometimes they found a thrombus at a situation here. So clearly the thrombus had rested here, the brain had become ischemic, the vessels had been injured, so when blood was restored, bleeding occurred. And he made diagrams. This is a basilar case where the patient obviously, here's the first thrombus, and you can see there's a cerebellar hemorrhagic infarct, and that had embolism to the basilar artery, and some had hemorrhagic lesions above. So at this point, the idea of brain embolism, the idea that emboli passed, hemorrhagic infarction, and atrial fibrillation all came to the fore. So Fisher had collected huge specimens, sometimes bilateral carotids and the cervicocranial vessels, and he analyzed the locations. I and other people asked him how he was able to do that. Oh, he said he paid the Dieners $5. And the Dieners actually then later went into medicine, and one became a professor of surgery. So he took these specimens and he put them on the autopsy table when a very extensive international research group visited Montreal, and they took the research group down to the morgue where Miller had splayed the specimens on the autopsy table. Now, the research group had seen various laboratories, and before they left, they told him, Miller, this was the best and most important research they'd seen in Canada. And he went home with a swelled head. He was feeling great. And the very next day, the chief of medicine, now, of course, neurology was part of medicine in those days, and Ed Mills was his boss. And Mills told Miller, why are you studying these stroke patients? They're already paralyzed. All that carotid work is just a bunch of crap. You'll never get anywhere in neurology studying stroke. So Miller knew sort of the writing was on the wall. He would never get anywhere in Montreal. The people at Montreal General weren't going to support him. He didn't really have the equipment in the pathology lab. The Montreal Neurological Institute was mostly epilepsy with Penfield and other people, and he knew he would have to look around. And Adams told him, why don't you come to Boston? And of course, he had known Adams for a while. So Adams told him, you have to set up shop. And these were the orders he gave him: set up a vascular neuropathology lab. So for all the years he was there, Miller had his own lab. Richardson also, of course, had a formal neuropath lab, but they worked very closely together. Organize and direct a stroke service. This was the first stroke service, actually, in stroke fellowship, that both Dr. Moore and I were involved. He was asked to perform and direct stroke-related research. He had to attend and teach on the general neurology wards, and Miller considered himself a general neurologist interested in stroke. So he continued to do general neurology, and you have to make a living. So he said, support yourself by caring for and consulting on private inpatients and outpatients. And Miller charged a pittance for his consultations, which often took hours, and refused to actually increase the rate or to chase the patients. So if you ask what was unique and special about Fisher, was his modus operandi, his way of approaching and managing patients and information. I think what we pass on are more our approach, a method. Trainees and individuals who we mentor learn most by emulating an experienced individual. Fisher's persona was that of a determined, persistent, untiring, and methodical student. He had lots of interest in everything: diseases, people, habits. He taught how to learn, how to systematically approach a topic and a patient, how to make a report, and how to communicate that particular knowledge. So these are some pictures of Miller. He was a big man, fairly imposing, almost like a gentle giant. This was him at grand rounds. He tended to sort of fumble when he spoke in public, and he, of course, he had notes. He had very few slides. Some of them were these large paper slides. This was him presenting at grand rounds in 1978. This is in his office, which will be piled up with manila folders and also past specimens. And this was what he loved. This was a neuropath lab and conference that would be on Tuesdays. And you can see here, looking over the brain, was E.P. Richardson. This would Miller. And what they would do during this session is they'd first have residents and then fellows comment, and then junior staff people. And then Miller would comment, and sometimes Adams would comment. And then Richardson would cut the brain. And of course, the brain had not been cut before. And then they'd have lively discussions. Now, of course, in the early 70s, there were no CT scans or MRIs. It would be mostly the clinical correlation. And here is actually the same group. This is E.P. Richardson looking over the cut brain. This is Raymond Adams, and this is Miller. And this is a picture of Adams and Fisher at that time, probably in the 80s. These are later pictures. This is Maurice Victor, who was, of course, a colleague. Miller, who was taller than the group. This is E.P. Richardson, Joe Martin, and Adams here on the right. This was really quite a group who had great respect for each other. and cross consulted with each other. So what were Miller's major contributions? I'm going to go through these in some detail. One is really Miller was very interested in how you examine people, how you take a history. So the first one was in coma, but there were many others. He then followed interest in carotid disease and transient ischemic attacks and transient monocular blindness. He then worked very much on the pathological causes and etiology of lacunes and the clinical picture. He really defined early clinical and pathological things in intracerebral hemorrhage. He analyzed the clinical symptoms and signs seen in patients with various vascular occlusive lesions. He really worked then further on atrial fibrillation, was really a sort of an amateur neuro-ophthalmologist, and was very interested in eye movements. He got that when he was studying the coma patients. He was very interested in higher cortical function, did the first ones with transient global amnesia, and did a lot of work on memory. He did some work on subarachnoid hemorrhage, especially when CTs came out. He was very interested in hydrocephalus and gait and wrote about that extensively. And of course, he was very interested in migraine. And then he did some further work on what has been called the Miller-Fisher syndrome. Trying to move the slide for this has always been an issue.
So you can,
There it is. Okay, so
yes.
the first is the clinical. So this was a very long article on the neurological examination of the comatose patient. The way it came out, he had visited actually Plum and Posner and thought or wondered if their work was actually based on clinical examination. And he examined 200 patients and wrote this very long, detailed analysis of what their physical signs were, eye movements, pupils, motor, and other things. He was also very interested in pulses and clinical exam, so palpation of the arteries in temporal arteritis, and here the ABC pulses in patients with carotid disease. He did some other papers on simple tests, so simple coordination of the fingers. He did that also of the toes. So he was very interested in bedside clinical examination and studied that in some detail. The carotid disease, here's a paper on the carotid artery and transient monocular blindness, which he spoke at length to the ophthalmology groups. And this was the first article, and he continued to be very interested in carotid disease. With the lacunes, he did some further work on the pathology. So this is a paper that he wrote with me. Actually, I didn't do any of the writing. He wanted to make sure that nobody touched his writing. So he wrote it up. I was actually the fellow who saw the patients, and then he wrote it up and he put my name on it. And he told me, oh, by the way, we submitted this paper. And he showed a basilar branch occlusion, and then the clinical work, pure motor hemiplegia, ataxic hemiparesis, dysarthria, clumsy hand, those were all done as clinical projects. And then he worked very hard on the mechanism and this segmental occlusion business of what happens actually in the vessels. So Miller would do serial sections, and he'd have thousands of sections. The pathology woman he worked with was meticulous in cutting these sections. And if you were in the office, he'd be packed high with folders, and he'd look, at serial sections, finding the lesion itself with fibrinoid and other changes within it, and continued that interest in lacunes. One of the first things he did, again with Bill Fields, he had studied the pathology of intracerebral hemorrhage and the clinical issues. This was before CT scan. So he had looked at pathology of one particular famous case of a pontine hemorrhage, and he'd shown that blood was in the center, and on the periphery were these fibrin globes. So he assumed that the pressure was under arterial pressure. It had pressed on adjacent capillaries, which then broke, and these were the sort of fibrin globes, so that the hemorrhage developed gradually. And the clinical picture actually developed gradually. And he also pointed out that the hemorrhages were often putamental, thalamic, pontine, and cerebellar. And then he talked about the clinical syndromes of intracerebral hemorrhage, which really helped people early really realize what the clinical anatomical correlation with also tumors and other lesions in the same sites. He was very interested in atrial fibrillation. Those original cases, he did a study where they looked with Phil Kissler at postmortem of patients with cardiac disease, both mitral stenosis and without, and showed that those who had clinical atrial fibrillation had more infarcts. And then they also had infarcts in systemic organs like the spleen, liver, and kidneys. And then he studied the hearts and found thrombi. And he wrote a paper originally to the geriatric group and said that patients with atrial fibrillation probably should be anticoagulated. The first group he spoke with were three very experienced cardiac surgeons who he had lunch with. And he told them all that atrial fibrillation was causing strokes. And they said, Miller, you're full of it. We have all kinds of patients with atrial fibrillation and they don't have strokes. They probably don't go back to those doctors. All three of the physicians who he had lunch with then had devastating strokes due to atrial fibrillation. So Miller said you ought to give anticoagulants before they have a devastating stroke, and was very instrumental in pushing that. He was very interested in helping the patient and clinically. He loved neuro-ophthalmology and made a number of different contributions here: dilated pupil, wrong way eyes, 1.5 syndrome, ocular bobbing, all kinds of observations on eye movements that he carefully watched, and on the nystagmus. And then he happened, when he was talking to the group in Houston about clinical signs, he and I guess some artists devised some cartoons where they had the symptoms and signs. This is one with a pontine, actually an anterior inferior cerebellar artery infarct. And this is one with an anterocerebral infarct where he wrote the signs and symptoms and the structures involved. It turned out when Victor and Adams wrote their book, they put this in. And also the internal medicine books, which were big sellers, they included a chapter that Adams was actually the chair, which included these diagrams. So actually almost every internist who read Harrison then it was exposed to these diagrams, which that's how they learned actually clinical correlations. Here, his study with Bill Carnes, who later went at the Mayo Clinic, and Charles Kubik, and this is what he would do. He would study the patients at postmortem. This was a patient with a lateral medullary infarct, and here you can see the infarct goes down toward the olive, and then here is the occlusion within the vertebral artery that also obliterates the small little penetrators that go into the lateral medullary fossa. So he would make these papers that would correlate actually the vascular lesion with the clinical symptoms and signs. He was very interested in higher cortical function, but never would speak about it till he had a chance to study it. The first one with Adams was transient global amnesia, and he was very interested in amnesia. So there were patients with bilateral hippocampal infarcts or posterior cerebral infarcts that involved the hippocampus. He wrote about concussion amnesia. He was very interested in amnesia in people with seizures. He wrote an article about disorientation to place, and then wrote several articles about various higher cortical function topics. Abulia and agitation actually were very interesting to him. He was very interested in how the brain worked. He did some work on subarachnoid hemorrhage, particularly after CT scan, and these were called the Miller criteria. He worked at this point with Phil Kissler and also Nick Zervis and Bob Ogeman, who was a neurosurgeon he did a lot of work with, and wrote about the relation of the vasoconstriction to blood in the spinal fluid. He was very interested with Adams in hydrocephalus, and this came out, the first case was sort of accidental. It was a patient of Selaman Hakim, who had come from Colombia who had had some abulia and gait problems, and they didn't know what was actually wrong with her. This was the pneumoencephalogram of that case, showing very large ventricles. When they did a shunt, she woke up and got virtually back to normal, then had some sort of accident. The shunt blocked, and she was back to her previous state. They put another shunt in, and she was in good shape. So he became interested in measuring actually the ventricular size, the ventricular span, and gait abnormalities in older people, and devised a way of quantitatively analyzing this as a cause mostly of gait abnormalities, but also abulia and also urinary incontinence. Miller developed a migraine late in life, was also a consultant to the migraine service, and wrote about a number of people who had episodes when they were older that resembled migraine and were usually undiagnosed, so-called late life migraine accompaniments, which he reported, and gave that lecture actually in Paris as a Charcot lecture, and was very interested in migraine and studied it on himself, where he developed visual scotomata later in life. And then he had some other cases when he came to Boston, and finally wrote up what's now called the Miller-Fisher variant of the Guillain-Barré syndrome. So quite a lot of different activities. And he would take each patient as an opportunity to study in detail and learn about it and collect it. This is Miller a little bit later in life with a younger me, and this is Dana DeWitt on the right. Here is Professor Moore with a big smile, Miller outside his house, and this is Bob Ackerman. And this is Miller and I a little bit later. And one of the things that we did, actually, Solomon Hakim encouraged me to write up this paper at Miller's so-called retirement. Everybody who knew Miller would know he would never recite these rules. These were just ascertained from knowing what he had. So I'm going to close with Miller's rules, which I think actually show a lot about his modus operandi and what his feelings were. The first was, for clinicians, the bedside is your laboratory. Study the patient thoroughly and seriously. A lot of people would be very serious in the path lab or in the science lab, but do clinical work happenstance. He said, this is your opportunity. This is the laboratory. You can spend time with a patient and really learn something. He said, you want to settle the issue as much as possible as it arises at the bedside. Don't leave a maybe. If there's a question, ask other questions, do other examinations. Don't just see the patient cursorily and order tests. Always be working on one or more projects. This will make the daily routine more interesting and useful. He had a bunch of folders that he would collect of different things. And then when he had enough of them, he would tend to write them up. When making a clinical diagnosis, this was just a practical one. Think of the 5 most common findings found in that condition. These could be historical, physical, laboratory imaging. If 3 are not present, the diagnosis is probably wrong. So you think about brain tumor, and you think about headache, focal neurological signs, seizures, mass effect, etc. If they're not there, you're probably not correct. Describe quantitatively and precisely in English, not medical jargon. So nystagmus, how rapid it is, how much amplitude there is, what the dispersion is, and don't just use numbers. So if the person is weak, they could hold their leg up for 5 seconds and it would drop, or they couldn't lift their arm above the bedside more than 2 inches. Then everybody who reads it or sees it can then understand what the deficit is. The details of each case are crucial. Their acquisition analysis separates the expert from the journeyman clinician. Become a collector, collect cases and puzzling phenomena. Their mechanism of meaning may be clarified later when other examples are gathered. He would put these in lots of manila folders that would be around when a new case would occur. Fully accept what you have heard or read only when you can verify it yourself. Remain very skeptical. There was a lot of junk that was been written before. Thoroughly read the literature, including early ideas and descriptions. We can't afford to repeat the history of neurology every decade. You could find Miller in the Countway Library. looking at the Virchow archives and the other things for background. He was very assiduous at reading the history and attributing things to other people. He thought that you need to know where the ideas came from, who was the first person who had it, and how they evolved. You can't redo this every year. Didactic presentations benefit mostly the lecturer. We teach best by listening, questioning, and demonstrating the Socratic technique. He hated to actually talk formally, but at the bedside was an absolutely magnificent teacher. Write often and carefully, share your ideas and observations. Pay special attention to the findings in patients with known diagnosis and conditions. This information will be helpful in the future when similar findings occur in an unknown case. So if the patient had visual scotomia and visual movement, listen for a long time as to the exact details of that. So when an unknown patient comes in, you can compare it with that. Listen to patients with amaurosis fugax. What are the details? How did it come down? Was it dark? Was it gray? Did it come from above? Did it come from the side? How long did it take when it came back? How did that happen? So these things, once you have it in your memory, you can use it for the unknown case. Be a good listener. Often even from the mouths of beginners come wisdom. He was able to hold, and he would ask the students or ask the residents or ask the fellows, what do you think? And it was very interesting. People would come to his office and tell him about a case, and he would keep quiet. And then he said, well, what do you think? Why do you think the patient developed this? And often he would learn from other people rather than trying to push them to parrot back what he had told them. Resist the temptation to prematurely place a case in a diagnostic cubbyhole that fits poorly. It's better to keep the mind open rather than prematurely shut. The patient's always trying to do their best. Be supportive. Never get angry with a patient or the family. There's a reason why they're there and sick. Maintain a lively interest in patients as individuals. Care more for the patient who has a disease than the disease that the patient has. And he was very interested in hobbies and what people did and how they reacted, and would spend many, many hours with them. He wasn't conscious of time. So if he thought there was some history here, he would go into great detail about what that patient did, what their activities were, what their interests were. And that's the end of the formal talk. After JP talks, I'd be glad to answer questions.
Yeah, Professor Moore, please unmute yourself. No, Professor Moore, you are still muted.
How's this? Now, can I be heard?
Yes, fine now.
Yeah, I can't do anything but supplement what Lou has already said with a few anecdotes that will fill in our personal experience with this guy. Bill Fields and he were interns together before World War II, and he told me on several occasions that after Fisher came back from his war camp experience, he was a much more sober guy than he had been before. When we knew him, he didn't own or carry or ever look at a wristwatch or the clock. In fact, many people in the training program who wished for a quick answer from him for a question would learn that an hour or two would go by while they had a Socratic experience with him that they hadn't asked for, but which they benefited from. He wasn't a gifted lecturer, and the medical students referred to him by the term shifting dullness. But I think that's mainly because he was easily distracted by other things and might stop in the middle of a talk to make a mention of something we had discussed the day before, others hadn't heard, didn't know what we were talking about. One anecdote, when we saw a man up on the rehab service, having had a number of large strokes in his 90s, Fisher asked him, ice cream? And he said, yeah, I like ice cream. He said, how about eggs? Yes, eggs. Bacon? Yes, bacon. And do you drink milk? Certainly. So he then turned to the group of students and said, difficult business, huh? He also drank a huge glass of milk at each of the Princeton conferences at breakfast just to annoy others who said he shouldn't do it. And many of the internists were a little exasperated when they would ask him to see a patient. It would take a while. Lewis also had this experience, but one of our experienced cardiologists I heard say to him, look, this is just a stroke and don't try to dress it up. He also had his own ideas of how he should spend his time. Lewis, I'm sure, had several of these, but on one occasion in the fall, I remember that he had a lecture to give at noon and he didn't appear. He had patients in the office in the afternoon and they finally gave up and went home. Then he appeared around 6 o'clock and he was had a red face from a suntan and was wearing an American flag in his lapel. And we asked, what happened? He said, well, Doris was bringing me to the hospital and we passed a Veterans Day parade. It just was wonderful. So I asked her to put me out. And the bands of Boston came by. There was popcorn. There was ice cream. It was just wonderful. So he was fully distracted for the day and gave no thought to the others who thought he should be spending their time with them. I don't think there's anybody who's quite like him. He and Ray Adams, at their own expense, published Transient Global Amnesia. When it had been turned down with uncomplimentary remarks, it's become a classic in the years since. And if any time Lou has had experience with members of their family, as we did rarely, his wife, always took pleasure in calling him Charlie, to his annoyance. On one occasion, we were at a dinner and somebody was talking about working into the future, and he said, they said something about his car. He said, yes, I like the car, but Doris drives it. I'll just work another year into retirement to pay for it. And she said, the way you're going to have to work 10 years before retirement. Well, it was a unique experience to be around somebody whose focus was not detractible by normal things like earning money, coming on time, being considerate, being easily distracted, willing to stay all hours to pursue certain things. I say he's a unique character, and those of us who had an opportunity to be around him, I think were heavily influenced by it, and we hope are carrying on that tradition in a somewhat attenuated fashion.
Yeah, one of the things that Jay mentioned is, so he would meet with his fellows toward the late afternoon, 5:30 or 6. Then they go and see one or two patients till about 11 o'clock at night.
Yeah.
And then he would call Doris and Doris would pick him up. But
Yeah.
he would go over some of the signs. So if the patient had, for example, a hemianopia, he would look at the brightness of the object, where it was located, whether it was moved, or what the color was, to analyze that particular physical sign or a motor sign. So it was really a remarkable experience to spend virtually a whole year, usually 6 days a week, 5 or 6 hours a day with Dr. Fisher and just watch his modus operandi.
Others who are attending should get an opportunity to speak. How about Bo Norvin, who I saw lounging in his chair before Lou began his talk?
So thank you so much. Can you hear me well?
Yes, I can.
Yes, wonderful. So I had the wonderful experience to visit Simile Fisher at Mass General during about a 10-year period. I came there 1985 as a young postdoc, and Bob Ackerman was my host at Mass General. He introduced me to Mille Fisher, to Raymond Adams, and I was taken to attend these daily meetings and the Brain Cutting Conference. It was a marvelous period, I would say, in my life. And there were many people there, but there was one occasion that caught Mille's attention to me, and that was a case that was presented by an intern. It was a young lady with a stroke symptoms, difficult to interpret what it was. The focality was really difficult. The CT scan was normal, and it was very puzzling what this was. And while they were waiting, the patient deteriorated, and after 4 to 6 hours or something like that, the patient died. At the next day, till the morning conference, they have performed a postmortem MRI, and the case was presented. So the discussion was in the hierarchical order, with people, senior people first, and they were very puzzling, and nobody really knew what it was. So when it came to me after a long time, I proposed this could possibly be on the venous side. It could be central deep venous thrombosis, and I saw the face of the presenter was changing, and this turned out to be the case. So he said that was very good idea, and he was very encouraged me. So I think that was a time when we really got into contact with each other. And then he took me to rounds many times. We developed a quite close personal contact, and he was very, very encouraging. And for me, came in there as a young person, postdoc with no reputation, and be treated this way at Mass General. I can say that this was a period that changed my entire life, really. So if there is one time in my life when I go back and say that this was a turning phase of my life, this was this visit with Bob Beckerman, Miller Fisher at MGH. It developed my contacts with other countries, and I can say without that, I would never have come into contact with all of you who I see as a panelist here, wonderful friends and colleagues, and everything that has been done ever since. This was a turning point, really. So I don't know if you can see this. This is a picture I took on US National Day, July 4th, 1985, just picking up my pocket camera. And I think it's a wonderful portrait. You can find it on the internet. I dedicated a review article to him, and this is another thing for my wall, a very nice letter from him thanking me for this. And 30 years after, for me, the circle was closed when I received the C. Miller Fisher recognition at Mass General. I was speaking at the Grand Round. So it's a wonderful experience, really, and it really changes my life.
Yeah.
And having had this opportunity to see him closely. Thank you.
Well, you're among the many who were stained by their experience, but turned out not so bad in the end. I want to mention that some of his fellows, he didn't really have many like Lou and I who were there for a long time, but many in India know that he spent quite a bit of time with Praful Dalal. And then there was Herb Karp, who went back to Georgia, Hiram Curry, who became a chairman of the family medicine department in Georgia, and Rene de Carey, who went back as a neuropathologist to Canada and whose contact we've all lost. But Lou and Bo, do you all know others who had earlier or later been there even for a short time or a few months or up to a year? I think I was the longest of them because of the 2-year experience. But I was funded by the NIH. When I took this job position, I asked Dr. Fisher what the money was, and he said, well, I don't have any. You'll have to find it yourself. So with 2 weeks to go before I started the fellowship, we sent an application to the NIH. I looked at his part, and he had his secretary type across the front, I give you my word, his time will be well spent. And I said, how are they going to know what we're going to do? He said, oh, if they don't give you the money, just think that they're missing a golden opportunity. You should just find it yourself. I said, yeah, but I don't have any. So I did get an award, $1,008 for the year. Lou, what was your setup?
Well, I think most of you know that Miller never kept any money in his pocket. Actually, it was apocryphal that he went to New York and he would ask Doris for money, and then he couldn't find her, so he just got on a bus and went home. But I met him, and he said, well, just come in July. Yeah, and right. We came and we sat around, and he told me what, where to get coats and where to get everything else. And then he said to me, I hope you've arranged your salary. And by this time I had 5 kids at home, and I could imagine going home to my wife and saying there's one small problem. So just like Jay, we applied to the NIH and we had a meager salary, but he was not concerned at all with money or time.
No, when I brought up the subject, he said, well, if it's the money, you should probably just go into private practice. And I said, well, it isn't the money, but there ought to be enough that I don't have to think about it. And he said, oh, yes, that's a good point. We'll get a fellowship for you.
Yeah.
Well,
he delegated all that to his wife, Doris, who was a very good manager. So she was actually in charge of the children, the money, the household, the car, everything but stroke. And he said, you have to dedicate your life to stroke and neurology. And that was his job. Everything else was related to Doris.
And she covered from him many times. I remember Fred Samaha, muscle guy we had at the General, who called Dr. Fisher up at 2 a.m. for help with a patient. And he said, his own wife doesn't know where he is. When I called to speak with him, she said, just a minute, I'll see if he's come in. And then she came back and said, no, he hasn't come in yet. So I think there might have been another message there. Well, sorry for these interruptions. And please, Dr. Vivek Lal, please take up the microphone.
Yeah. Can we have comments from Professor William Carroll before Vivek Lal speaks? WFN President, Professor William Carroll. Yeah.
Thanks very much. Thanks very much, Lou, and to Dr. Moore. It was really, really nice to sit and listen to this. I didn't ever meet Miller Fisher, but I did spend quite a bit of time with Ray Adams, E.P. Richardson, when they visited and stayed in Perth. Soon after I started training. And I must say, listening to Lou's account of Miller Fisher's modus operandi reminded me that we've been so fortunate to be at what is arguably the last bastion of clinical medicine, and that is in neurology, and how important it is still today to take that history accurately, to get the temporal profile, the evolution of a symptom or a disease process, and to resist the temptation to go straight to the scan and think that that's the end of it, because it isn't. And I thought that shining through Lou's talk was that point, which I hope the younger people pick up on, because it is a fascinating way to understand what is happening to the brain during disease processes. So I'd like to thank Lou and JP Moore for that, and Bo Norving, and also the Indian Academy of Neurology, and particularly Chandrasekhar Meshram for starting this wonderful series. And I look forward to hearing from Alan Roper the next one about Ray Adams. So thank you all.
Well, thanks to John Lester in Australia for his role in contact with Miller Fisher.
True.
Yeah. Can I speak? Chandrasekhar.
Yeah, sure.
So I think Professor Kaplan has really covered his mentor exceptionally well. And I'm particularly fascinated by Miller Fisher. I remember on rounds when we would ask a question, who described this syndrome? So I often tell my residents, if you don't know the answer, just say see Miller Fisher. 5 times or 6 times out of 10, you will be correct, right? Because he described almost everything new, right?
Yeah,
so you're going to be correct. You don't have to, remember many names. You just remember one name and you will be correct more than 50% of the times.
Right.
So that's how we kind of, remember C. Miller Fisher. And I was particularly fascinated by, of course, I never met him, his article on, migraine variants. And if I'm not wrong, that was published in the Canadian Journal of Stroke. It was published in a Canadian journal. It wasn't published in Stroke. It was published in a Canadian journal on Fisher's variants of migraine, the migraine equivalents. And there is a fairly large population of these patients who move from pillar to post without a proper diagnosis. They go through a whole lot of investigations today. There is no dearth of technology, but there's a dearth of people who think about what they are, what they are investigating. So that's where Miller-Fisher, the lessons which he taught us are relevant today as ever they were in the past, unless the younger generation doesn't learn to think and interpret every investigation that is done with caution and with a judicious, integration of clinical judgment with the technology. You're probably going to give, you're not going to give your best to patients. The other thing about Fisher was the very famous ataxic hemiparesis. We still remember we had seen a few patients of ataxic hemiparesis in our setup. We had an excellent neuropathology setup long time ago, and almost every patient of neurology who succumbed to an illness underwent, autopsy. That was mandatory at that time. Things are different now, and we picked up a lot of infarcts in the basis pontis in a few patients of tubercular meningitis. These patients of tubercular meningitis, they would come with altered sensorium, and they would, of course, succumb to the illness because there wasn't much to offer at that time. And majority of them also had infarcts in the basis pontis. So that's how I think his contribution to neurology is phenomenal. He's a colossus. And it's just appropriate that Professor Kaplan and Professor J.P. Moore should be discussing them. I must honestly tell you, as a resident, Professor Moore, I read your book, and as a resident, Professor Kaplan, I read your book, right? And you wrote on, Professor Kaplan also wrote on stroke, and Professor J.P. Moore wrote on stroke. And there's a joke which I often share with Professor Kaplan, that, the year was 1990. So I was looking to do something where you didn't have much to do, to be very honest. So I came across this subject of stroke. There wasn't much to do at that time. I'm talking of the early 90s. So I thought that's a very good way of making money. Do nothing but earn some money. And so I read Professor Kaplan's book on stroke. But I was so fascinated that I got, I must confess that it was a 1984 edition, the first edition on stroke which Professor Kaplan wrote. I think, was it 1984, Professor Kaplan? I think it was around that time. And I read it around 1990. And I confess honestly that I got 20 photostat copies of that book, and I distributed it free of cost. I paid for that book from my own pocket, so don't contact your lawyers, Professor Kaplan. I didn't take a single penny, and I distributed that book to all the residents. I felt that was an incredible book to read. Professor Moore and Kaplan, I still have your books with me. I've shifted a house 20 times, but every time I shift a house, I take these two books to my next house, and my wife doesn't understand why. That's okay. That's typical. That's nothing new in that, right? So thank you so much for being with us. It's been wonderful. My whole department is watching you, and I'm really grateful, Professor Maheshram. You have really brought us face to face with so many giants in the same go. Thank you so much.
Thank you. Thank you, Vivek. Can we have comments from Professor Raj Shakir?
Thank you, Chandrasekhar. Thank you very much. I spent a year and a half in Boston, Beth Israel, with at that time with Poser, Charlie, and then the rest of the time a year at Mass General. So I had the honor of working with both Ray Adams and Miller-Fisher. And what struck me there is the Tuesday afternoon pathology. I have never seen so many brains in buckets. And I'm sure that Lou will remember the many residents, every resident, the buckets are numbered and the brains are kept for a month or so. And then you attend the brain cutting sessions. And the knives are so sharp and the slices are so thin, which were commented upon by Dr. Kaplan. And that is how we learned about stroke. And one person who has not been mentioned, but I'm sure Alan Roper may mention her, it's Tessa Headley-White. Tessa Headley-White was the pathologist. And she was a lady who was an English lady who was qualified in Newcastle, but I think she spent all her adult life as the neuropathologist at Mass General, because at that time, I think it was in the Warren Building. So remember the case presentations and the brain cutting sessions. I think the brain cutting sessions at Mass General are unique. I have not seen them in Europe where I trained, and I would like very much for Dr. Kaplan to comment on the Tuesday afternoon brain cutting sessions where the diagnosis is made. Thank you.
I actually introduced them in Chicago when I went there, and I would be the pathologist for half the time. So we would do it the same way. And I think it was commented that it would be hierarchical. So you'd ask first the junior resident, then the senior resident, then the junior staff people, and we would all have to stick our neck out before the brain was actually cut. I thought it was a wonderful session, and also learning the neuroanatomy. A lot of the residents these days don't know the anatomy, but actually cutting the brains and looking at them was very, very important.
Thank you.
Professor
Peki
İstanbul turundan kırmızıya dönmüş.
Aa, gerçekten mi?
Evet.
Ne olacak şimdi? Komik.
Ankara 39'da 54'e yükselmiş. 100 binde.
Hepsi artacak galiba.
Yeah, Professor Norvik, can you mute your mic?
Tüh. Bu işten nasıl sıyıracağız ya?
Sırayı
Professor Norvik,
Yes, actually, I'm muted. I think we are many people on the same line. So I'm muted now.
Karadeniz.
Yeah, Professor Grisot.
Thank you. It was a fascinating display of history, and I just have an experience of having met him for one day, like a blink experience, which reflects all the things you said. I worked with Professor Jellinger at the time, who is also from the same tradition as brain cutting and clinical neurology, and I was enabled to visit him for one day in Boston, and I was asking him about a reflex when the glottis closes, when I'm immersed in iced water, which interested me at the time. And he immediately knew some suggestions of literature where I could follow. But what has influenced me up to that day, and I keep telling this to all my residents, is when he took me to the rounds, he took very much time to see the patients. And he said, it takes what it takes. Time doesn't matter. And this has influenced many of my approaches to see patients. Thank you.
Thank you. Professor Yuji Kazi.
Can you hear me? I think Professor Kaplan's lecture was quite much influencing to me because this is just a kind of deja vu of my first time student experience to listen to William Osler's life's lecture in a medical school. And so I do think that Osler and Miller do have common personality and common habits or common points that we can learn. And I'd like to thank again for Professor Kaplan for giving a very nice lecture and organize these things for Indian Academy. Thank you.
Thank you. Professor Jairaj?
Thank you, Professor Kaplan, and it was a very inspiring talk. And I had the opportunity of writing a book review for the latest book on Professor Miller-Fisher, the stroke in the 20th century. So I wrote it along with one of my colleagues for the Journal of Stroke Medicine, which is the official Journal of Indian Stroke Association. So some of the things that you had mentioned, it was there in the book. It was so lively to read that book, and it was so inspiring. And I had a few opportunities to come to MGH. I think in one of the trips, I was with Anish Singhal, and I joined the ward round, and he showed me the neuropath lab, the ether dome, and during the ward round, there was a case of the resident was presenting, and immediately, there is in the previous day admission, and the next day he was presenting. So he had reviewed the literature, the science, and then he was showing an article written by CMF. And it was so inspiring to be there at that time. And thank you very much.
Yeah, Professor Steve.
Hi, I want to thank Dr. Kaplan, Dr. Moore, Dr. Norving for such wonderful thoughts about a great giant in neurology. I want to mention Dr. Kaplan for a moment. He may not be aware, but I missed working with him by about one day. I trained in Chicago at the University of Chicago, and the most important site of our training was a hospital called Michael Reese Hospital, where Dr. Kaplan had been the head for several years. His last day at Michael Reese was, I think, December of 1984. And my first day as a resident there was January of 1985. So I just missed working with Dr. Kaplan. So it's really been an incredible pleasure today to be taught directly by him about this great giant. One other comment I want to make is that there are 3 papers that have been really important in my own career. I asked residents to read it, and that's the Sumner Ophthalmological Observations, the original Miller-Fisher paper, and the late life migraine accompaniment paper. I think those are just wonderful examples of how to see patients, how to collect your cases, how to learn from your cases, and how to write. And I think those papers are just as relevant today as they were 30 years ago. So again, thank you to all of you for such a great session.
Thank you, Steve. Gagan would like to say something. Gagan or Professor J.M.K. Murthy.
Dr. Murthy first.
Well, if I'm invited to speak again, I just want to say how all of us have been influenced by this man and the tradition that he represents. I think many who were attracted to work with him had the same views in miniature or in yet to be developed, and which under his tutelage were developed to a strong level. He has, although he's gone to his grave now over 5 years, up until the last, when I saw him in February before he died in April, he was still contributing to a controversy in the Lancet, and was disappointed that he couldn't see clearly enough to write and see his own writing, and had to have somebody write it and send it for him. So right up to the last, he was making his own decisions, and he made his own decisions on his passing. His son called me to say that Dad said that's it, and he turned his head to the wall, and in 3 days he was gone. So he was in control and an example right to the end.
Can I say something? Can I say something, Professor Chandrasekhar?
Yeah.
I think, his tradition and his spirit is being kept alive by the continuums which Professor Stephen Lewis edits. And I need to thank him in particular, because those continuums they are the lifeline of neurology today. And I need to thank Stephen. I'm meeting him face to face after Dubai for the first time. And they are actually, in keeping with the tradition, these greats have really taken the heights, neurology to heights. So it's mandatory for all my students to chew the continuums. They're supposed to chew them. They might not touch any other book, but continuums, if they don't read, I don't spare them. And I'm glad that, Stephen, you're listening to what I'm saying. Just keep up the Fisher tradition, please. Thank you.
Thank you.
Thank you.
Were these continuums initiated by Dr. Miller-Fisher?
No, he's the chief editor. He's the soul behind the continuums. So I thought I must thank him.
But did Dr. Miller-Fisher, initiate them?
No, I don't think.
Okay. Yeah, no, I mean, it's so inspiring. I mean, it's perhaps one of the most wonderful evenings and very fantastic. And I'm not sure how much can I thank Dr. Louis Kaplan for this really wonderful account of Miller-Fisher. Clearly, I mean, I can say I started training, not in the Miller-Fisher era, but once he had, but it's related to stroke, but outside the purview of stroke. So that just tells us his wide spectrum and range, and how he could think out of the box at those times. Clearly, it must have been really difficult to think about what we think is very natural today. So thank you, Dr. V. Kaplan. Thank you so much.
Professor Murthy?
Thank you.
It's just been a fascinating.
Please unmute yourself.
Thank you, Professor Lewis Kaplan, for telling us the inspiring and fascinating life of Professor Miller Fisher. I had an occasion in 1990 to meet him and follow his board rounds one day. He is a very fascinating personality. Thank you.
Thank you. Professor Moore, you can take up the questions. There is a Q&A box, and you can take up the questions or comments from the audience, please.
I think one thing is even with availability for our advanced neuroimaging techniques, why for spinal TAS, lacunar infarction, spinal hemorrhagic strokes are less worldwide? This is a question by Alim from Trichy. Question to Professor Lewis Kaplan. Can you hear me?
I didn't understand the question.
Even with availability for advanced neuroimaging techniques, why we are missing spinal strokes?
Well, the spinal cord is a very small area, and it's hard to image the inside of it, and the blood vessels that supply it are very small. So again, a lot of the work on spinal cord disease, which has been left out in spinal cord stroke, is he's still evolving, and filming the aorta and the aortic branches is important. But again, we really, in spinal cord disease, we really make the diagnosis clinically by the evolution and how it evolves and the risk factors of the patient. But I'm not sure the imaging is going to be the answer.
The next question is only comment thanking you, Professor Kaplan, about telling about Professor Miller Fisher. The question from Satish Chandra is, you are a great teacher yourself. What do you think that you have learned from Professor Miller Fisher that has changed you? It changed your approach or career? To Professor Lewis Kaplan.
Yeah, well, there was an interview. Fisher was the honored guest of the Neurosurgical Society, and I had the honor of interviewing him. Actually, that's on YouTube. And at the end, he asked me, what about you? And I said, it really changed my life. So I thought that 1 year really changed my thought about virtually everything. Now, before that, I had been the last of Dr. Derek Denny Brown's residency, and Denny was quite an extraordinary guy too. Denny had done work on everything, but what Miller taught me, I think, was quite a bit about humanism, quite a bit about how to work, and that changed my life completely. And I think Bo Norvig has said that. I think JP has said that. I think that emulating someone of that quality changes you. I don't think we learn so much by didactic speaking. It's really following somebody who is the mentor. And ever since then, actually, for many, many years, I would use him as my oracle. So if I had a difficult case, I'd give him a call. It would usually take an hour or two, as JP said, and he'd ask me the details. And then he'd ask me, he said, well, what about this? And I said, gee, I don't know. He said, that's the key. He said, know the question. And then he would say, if you get that answer, you'll understand the case. So even after the years, he really helped with that sort of a way to analyze a case, what questions to ask and what to pursue.
Professor, question to Professor Moore or Professor Kaplan. Whom do you think, if at all there is one, would you call an equivalent of Professor Miller Fisher in the present day neurology world? This is a question from Kawasa from Srinagar.
Well, I would say we pass that answer to Dr. Kaplan, who is the honored guest today.
I think it's very different. So these are different times, and I think that when he was practicing before the imaging area, and where really there wasn't that much in the way of subspecialization, now a lot of the senior giants are really much more specialized, and I think a lot of them you're going to hear about in ensuing talk. So Bud Rowland might be one. I think Newsom Davis, Dr. Wadia, who were very general. I think there were a lot of people who were really giants and performed around the same time, but were very different in what activities they have. Marsden was another that comes to mind. So their number, and hopefully we're going to hear about them in subsequent months. I'm really looking forward to it.
As a comment and a question, I am from Chuk Bean. I remind awe of my relationship as a child neurologist who was taught by Professor Miller Fisher. I wonder why it is so difficult to continue to teach my residents the same type of clinical care rather than the rush to imaging and tests. Thoughts? Any thoughts? Charles Bean, Emeritus Professor of Child Neurology.
That's a question we're all struggling with. Too many patients, too much scheduling, too much emphasis on money. So how do you pay a teacher who teaches rather than has to earn his own living? And the internet is a big part of that, of the residents wanting to print out the most recent things right away rather than spending time at the bedside. And then there also the issue about the medical record and the residents having to spend all their time with the record. So the residents spend about a third of their time actually seeing patients. So this is a huge problem, and how we solve it, I think, is we all have to work on.
Another, I had an opportunity, this is from Joe Brainer and Red. I had an opportunity to work with Professor J.P. Moore for one entire year. All of the Professor Miller's rules are strictly followed by Professor Moore as well. So Professor Miller is still disseminating his rules. He is still alive by the hands and minds of former fellows. This is a comment.
Yes, I am still alive, and I'm grateful for the comments and the impact that we may have had on one or more of the people who made a entry today.
Thank you for questions.
Thank you, Professor Murthy. Any other comments from anyone or any memories? I think we had a great,
fantastic,
great day.
Great day, very inspirational, and I think I also remember when I delivered Vivek the presidential oration, the first photograph I showed was of Miller Fisher.
Yes.
That how he inspires everyone and how he had inspired me, and the various aspects of his life, the rules that even the simple thing that collect cases, keep collecting cases, they will become handy sometime later in your life.
Yeah.
So I think it's a very wonderful message, and an excellent talk by Professor Louis Kaplan, and a great interaction by everyone. Professor Moore, thank you very much for chairing the session and interacting. Professor Bo Narving, and Professor Vivek Lal, Professor
My whole department is listening today. They're all there together. It's not easy to get them on a weekend. I mean, the moment my back is there, they all run away. But they're all listening today. Thank you.
Professor Carol for joining, and Professor Raj Shakir, as always, that he has attended all the sessions, and Professor Wilfeng Griswold, Professor Steve Lewis, and today we had Professor Yuji Kaji. And thank you very much. Thanks, Dr. Jairaj and Professor Murthy. And I think I would like to thank everyone. The next month, the first Saturday, 3rd April, Professor Ellen Roper has opted to speak in the month of June. So next time it will be Professor Kailash Bhatia speaking about David Marsden. So keep your date 3rd April. And after that, it will be John Newsom Davis. Angela Vincent will speak about John Newsom Davis, and then Ellen Roper about Professor Raymond Adams, and then Professor B.S. Singhal will speak about Professor Noshar Wadia. So we are going to have a great treat and great inspiration, and I'd like to thank everyone for being with us. Thank you all. There are so many large audience today participating in this session. Thank you very much.
Thank you.
Thank you again.
Thank you, Gagan.
Bye now.
Thank you, Sir Moore.
Thank you so much.
Thank you.
Professor Kaplan, thank you very much. Thanks to Steve.
Thank you.
Thank you. Thank Professor Bo. Thank you. Thank you, Serif Noor.
Thank you very much. It was fantastic.
Yeah, thank you. Thank you, Mansi.
Yes, sir. Pleasure. Okay, I'll end the session now.